دلوقتي هنتنقل لدراجز used in hypertensive crisis. واحنا قلنا we are going to deal with drugs in hypertensive urgency and emergency، وفهمنا الفرق بينهم ان واحد with end organ damage اللي هو emergency، واحد without end organ damage اللي هو urgency. والاتنين بيبقى عندهم البلاد بريشر في السيستوليك اكتر من 180 وفي الدايستول اكتر من 120. طيب بالنسبة في الهايبرتنسيف urgencies السيمتومز are bizarre not that selective ومتنوعة and it could be headache, it could be palpitation, shortness of breath, lightheadedness, bleeding per nose and so on, indication ان البلاد بريشر عالي جدا. طيب policies adopted in treatment of hypertensive urgencies what are they? We use oral antihypertensive medication. So in urgency, we use oral. We don't want to rush very steep. We don't want this. We start rapidly to lower it. We initiate rapidly, but with oral. So it will not be that aggressive. And why are we doing so? To induce controlled reduction of the blood pressure. Our aim that it should be lowered within 24 to 48 hours. It should be controlled within that range of time. Why don't we want that to happen very, very acutely? Why? Because if we do it acutely, we have agents that can immediately drop the blood pressure. But if we use agents that immediately drop the blood pressure to a great extent, this rapid reduction may induce sudden change in perfusion pressure of organs. الأورجنز دي متعودة على set point من البارو ريسبتورز بليفلز معينة بقالها for long بتشوت فهو متظبطة على abnormal أو يعني بقى الأوتو ريجولاتوري ميكانيزمز are not sensitive فبلانتد، فبالتالي الشوتينج ده هي ما بتحسش كانت بيه، ولما هبدأ أنزله هيحصل distortion والريسبونس هيبقى not that good وهيحصل low perfusion of organs and this is not wanted. So the only message is you do rapid initiation to try to drop the blood pressure, you use oral medications and this could be يعني achieved. You accept the achievement from the first 24 hours to 48 hours. It could happen in hours. It's okay. You begin to see the established control. While on the other hand, in hypertensive emergencies, what do we use? We use the opposite. This is an emergency condition in which end organ is affected and any of these end organs may be affected. The eye, there may be hemorrhage, papilledema, if she's pregnant, definitely there will be eclampsia. If there is if to the brain there we may get manifestation of stroke, we may get agitation and delirium and so on, and you can keep on counting many things. And the target organ affection is to different is expressed by the organs supplied by different blood vessels going to the retina, to the brain, to the heart, to the kidney, large arteries in the distal or distal in the lower limb, in the upper limb. So it's everywhere and we have to be very careful. Now, the pathophysiology of that is that with this situation, we are elevating much the RAS system, unpredictable, and because there is severe rheological forces going on in the big vessels and the medium-sized vessels, so these rheological forces are showing eddy currents and they are injuring the endothelium as well. So we may get a prothrombotic state. So this system with that, this upregulation with that upregulation will definitely cause endothelial injury and ischemic insults in a way that we get target organ damage that is being expressed, and it is very clear. You will find a target organ presenting as a manifestation. Target organ affection will be presenting as a manifestation. It could take the line of stroke, it could take the line of kidney problem, it could take the line of anything. So this is prone to happen. In the eye, you may get papillary edema and so on. So here, this time, what is the policy adopted? Contrary to oral medication, we use parenteral medications. And the choice, remember, this is another point in this type of emergency. The choice depends on the predominating end organ affection. So if it is causing the cause and the presentation is in the CNS, we would rely on certain drugs that could be different from that in the heart, that could be different from cardiogenic, from problems with infarctions in the heart, problems with eye manifestation, and so on. Sometimes, in some instances, all drugs would work, but sometimes we prefer to select some drugs over the other drugs. فأهم حاجة إن احنا نحط في دماغنا إيه هو التارجت organ damage، وبعدين from the start قلنا we will select a parenteral titratable short acting antihypertensive. وليه الكلام ده؟ علشان أنا هنزل الضغط immediately، فعاوزة في أي لحظة أشوف خلل أقدر أستوب. فعشان كده لما بعوز البارنترال عادة بختاره بقى من الحاجات اللي شورت اكتنج، يعني لما اقفله الايفكت هيروح، واقفله اكتر بايه؟ مش ان انا ادي بولس باي انفيوجن، لما الاقي الوضع مش عاجبني اروح قافله الانفيوجن، ما بطل المحلول اللي فيه الدواء، خلاص the story will not be threatening then. فthis is important. The policy is to start immediately as continuous infusion. Our aim in starting immediately, of course, we want to rescue the end organ. We want to prevent further deterioration of end organ damage. We do that by stepwise control. Last time in the urgency, we don't go stepwise, but this here, we go stepwise controlled reduction. And when we calculate the reduction with the mean arterial blood pressure, which you know is double the diastolic pressure plus the systolic pressure. We add all that together and then we divide by 3. And accordingly, this is what we do, as if we have a steps or stairs. Okay, the first initiation will be aiming to reduce the elevated blood pressure up to 25% reduction over an hour. This is permissible over an hour. So if you have systolic blood pressure of 240 and diastolic of so and so, and you calculate and you wind up that your mean arterial blood pressure is 220 or 230, you want to reduce up to as much as you can within the first hour, up to you want to take it off 25%. Then the next, if that is achieved, well and good. If that is not achieved, then the reduction will go over the next 2 to 6 hours at a slower rate. And we aim at decreasing, we want to reach a final goal of 160 to 100 over 110 millimeters mercury, not less than that. So that means in the first 1 hour to 6 hours, you don't want to go beyond this. If that happened in the first hour, well and good. If it did not happen, then you continue. So you keep this range working together throughout the first 6 hours. And then the last step, you begin to normalize. You want to normalize to the target blood pressure, the regular blood pressure. You want to go to normalize the pressure. You want it to be reduced, if you succeed, as much as you can, to 120 over 80 with slight fluctuation. This will be slow, but as I said, you want to, I'm sorry, I said you want to normalize. When we normalize, we do not I'm sorry, I said something wrong. We do not want to normalize less than 140 to 90. Again, not to affect the perfusion pressure, because these tissues have been accustomed to increasing pressure, so we don't want to cause a crush in the perfusion. So I repeat again, we go over the first 6 hours down to 160 over 110. 25% of the lot or of the sum of the rise should go down in the first 1 hour, and then we can continue. If still we have remaining things that were not reduced, values that were not reduced, and the target was not reached. And then after 6 hours have passed and you achieve the goal, you go down to normalize the target, but you normalize it to not less than 140 to over 90 millimeters mercury. There is certain situation when you want to normalize it less than that. Okay, you went rapid reduction to that. Beyond that, this is in aortic dissection, in acute pulmonary edema, and intracerebral hemorrhage. You want to lower it. You want it to decrease less than 140. It is recommended in aortic dissection. There is bleeding, as you can see. There is effusion. So the things with bleeding, effusion, and so on, you want to reduce beyond the 140 to over 90. Now, the different pharmacological groups that could be used in hypertensive crisis in general, we agreed that they could be used whether in urgency or emergency. With emergency, we have to use parenteral. With urgency, we use those that are present, those of them that are present in oral form, or others as well. But the ones I'm going to show you are mainly for the hypertensive emergency. But some of them, as I said, if there is oral preparations, you can use them as well. Now, let's see. The nitrates, we have two preparations. We can use the nitroglycerin and sodium nitroprusside. The adrenergic blocking agents, we have three preparations. We have the labetalol, esmolol, and phentolamine. The calcium channel blockers, the most favorable is nicaradipine, and others. Hydralazine is also used, and it's mainly used for certain indications, but there are other drugs like captopril and things like that where we can use in the urgency as tablets as well. Now, let's focus on a group by a group. Let's start by the nitrates and the calcium channel blockers. Regarding the nitrates, the nitroglycerin, you know that we have the sublingual. We don't use it in here. You can use it in the urgency if you are stuck and you can't find a drug, but it's not that common to be used. It is more common when the patient has hypertensive emergency and the affected organ is the heart. So nitroglycerin is more favorably used in that. The nitroglycerin is this time given injectable. It is put in infusion. Our aim is to lower the preload and the afterload. And from your studies, you know that the nitrates induces lowering of the venular more than the arterial. This is regarding the organic nitrates, of which is nitroglycerin a group. So organic nitrates, nitroglycerin, the most common of them, increases or lowers the ventricular, causes dilatation of the ventricular side than the arterial side. So definitely it will decrease the preload more than the afterload, and it can induce this action within minutes, very small, very quickly, and it is very short acting. So that's why it's very easy to be titrated. As I said, this is more recommended if the emergency or the hypertensive crisis is happening and is, or maybe the cause of the acute myocardial infarction, and the symptoms you will know all about what will happen, and this is very important to take in consideration. Nitroprusside is a nitrate, but it is not organic nitrate. It is sodium nitroprusside, and this preparation is not usually given in or during anything related to the myocardial infarction. They are potent antihypertensive agents. They are very good to lower the blood pressure. They are more arteriolar than venular, opposite to nitroglycerin. So the inorganic nitrates, of which sodium nitroprusside is one of them, are more favorable to be arterial, while the nitroglycerin, which belongs to the organic nitrate, is more venular. Anyhow, when we use sodium nitroprusside, we have to understand that it is very efficient. It will decrease both. It will decrease both, but it is more arteriolar than venular. I don't know, it's written wrong here or what? It's written wrong. It's more arteriolar than venular. I'm repeating in words because it's written wrong. And then it acts very rapidly, lasts for 2 minutes. If you stop administration, the effect will go very quickly. It is favorably given in all types of hypertensive emergencies, especially those related to acute pulmonary edema and in many other things. The only exception to giving sodium nitroprusside is during intracerebral hemorrhage, because there is contraindication for that. We have to know that for preparing a solution or for infusion of sodium nitroprusside, it has to be locked in a bottle that is light sensitive. So if you have an infusion, you have to wrap it all very tightly with aluminum foil or use dark bottles. Of course, dark bottles are not always available, so the solution is in the emergencies, they have aluminum foil where they can wrap the sodium nitroprusside, because if you don't wrap it, it is very light sensitive, it breaks and it will be inefficient. The problem with this product that on prolonged use, it has certain metabolites, and these metabolites, when they accumulate, they could be toxic. What are these metabolites? They are the thiocyanates and the cyanide. So please, we do not give them for prolonged time, especially in cases of renal and hepatic disorders. If we move to the calcium channel blockers, nicardipine is a very important calcium channel blocker that is selectively being given in what type of end organ failure? It is in the cerebral. So any neurosurgeon or neurologist, when he meets any situation related to the CNS, he uses and prefers nicardipine. Nicardipine is a titratable intravenous dihydropyridine, and it has the merit of increasing the cerebral perfusion, and it is selective a cerebral vasodilator. Of course, it can reduce it will lower the blood pressure in all the arteries, but it is selective effect is on the cerebral circulation, and it can pertain good cerebral perfusion and good oxygenation to the brain. So whenever we see any cerebral insult, if nicardipine is there, it is the optimum drug to be given. If we move to the adrenergic blockers, we have the labetalol. Labetalol is a non-selective beta blocker. What do we mean by this? It is essentially does not it blocks both it blocks both betas, beta 1 and beta 2. So it is not cardioselective, and at the same time it is selective for blocking alpha 1 as well. So that means it will work in our body by blocking beta 1, beta 2, and alpha 1. It is given in bolus, and then a loading dose, a bolus loading dose, gradual, and then by infusion to continue. It acts within 5 minutes and it lasts 3 to 6 hours after discontinuation. لما نبطله الإفكت بتاعه هيروح بعد. فشايفين this is long، مش زي الحاجات السريعة اللي كنا بنتكلم عليها قبل كده. So it has a long duration of action. It could be accepted in all types of hypertensive crisis or emergencies, except if there is acute heart failure, because it's still a beta blocker, and in very severe heart failure, when the ejection fraction is below 40, beta blockers are not recommended, and it has a beta blocking action. So that's why it is not recommended in acute heart failure. The merit of this drug, it is balanced, so it does not produce tachycardia like that of amlodipine, nifedipine, and other calcium channel blockers that cause sudden drop, or the nitroglycerin, because nitroglycerin as well can cause some tachycardia, but it can, because it is not selective, it can cause bronchospasm and some tingling and hypotensive manifestations. Of course, needless to say, as we said, it is not given in heart failure. Of course, it's not given in asthmatic, and it's not given in grades of bradycardias, where the beta, again, blocking action is not demanded, because this will cause further degrees of cardiac block in the conducting system. This is the first adrenergic blocking agent. The second adrenergic blocking agent that we can give is esmolol. Esmolol is a very rapid acting selective beta-1 adrenergic blocker, and if we stop administration it only lasts for 20 minutes. Why؟ يعني سبب السرعة دي ايه؟ ده مش common to the beta blockers، ان هو hydrolyzed in the RBCs، ف within the circulation في حاجة quickly hydrolyzes it, and it is given by loading then infusion for how long you want to give it. It is helpful in the operative field. In the operating theaters, we usually have sodium nitroprusside, and we usually have esmolol. So if anything goes wrong in the operating theater where there is a hypertensive emergency, it could be caused by some anesthetics used, so they have something to deal with quickly. Also, you know that in aortic dissection we care to lower the blood pressure and quickly, so esmolol is ideal, and it is not, it does not weigh off very quickly in 1 or 2 or 3 minutes like the nitroglycerin and the calcium channel block. So it takes a little bit of time, but you can use it in aortic dissection to lower the blood pressure. Of course, it is not given in first degree block. Still, it is a beta blocker. The others, when we say the third one of beta adrenergic blockers is phentolamine, and this is an alpha 1 blocker. It is competitive reversible alpha, especially the alpha 1, and it is given whenever there is the emergency is due to sympathetic overactivity, especially when it is induced by drugs of abuse, like cocaine and so on. Drugs of abuse can cause emergency hypertension, and also it could be given in cases of pheochromocytoma, because there is excessive pouring and bouts of pouring of catecholamines in the circulation. But when we give it in pheochromocytoma, you have to remember ان انت لازم you have to give with it a beta blocker علشان cover the heart as well, لان الفنتولامين does not cover the heart. If you're going to give it عشان السيركوليشن البلاد بريشر عالي جدا, you give phentolamine, then you give with it a beta blocker for the sake of the heart. The other زي ما قلت لو هو على قد الامرجنسي اللي هو we are keen in drop the blood pressure وحاجة parenteral, hydrazine is another drug that has direct effect on the vascular smooth muscle cells. It increases nitric oxide release and inhibits its oxidation. It decreases the release of intracellular calcium, so it does not permit ان يحصل vasoconstriction، وبالتالي it's a good aid. ومن الحاجة الفيري famous ان هو during pregnancy ساعة الإكلامسيا هتاخدوها في البريجننسي في سنة 5، حاجة emergency situation in pregnancy. You can give hydralazine, you can give labetalol sometimes. وزمان كنا بندي ألفا ميثايل دوبا، بس يعني ما بقاش that common anymore. But it did stood the test of time. It has no teratogenic effect. والدراجز اللي بنقولها لكم دي has no teratogenic effect. Others can include, as well as I said, captopril, some of the parenteral available ACEs if there is, so you can use them. But generally, what I have said is enough to revisit. And with all that, I hope that you understood very clear. If you have any questions, you can call on the secretary and refer to us for any questions. And all I care for is to wish you good luck. This lecture is put in 2 parts because while I was registering the lecture, I put my thumb wrong on the cursor, so it locked it and caused problem. So you have a part dealing with the heart and you have a part dealing with the blood pressure. Thank you again.